Okay. A lot of people ask, well, Dr. Rutledge, how did you go from being a general surgeon to doing the MGB? And it turns out that for 20 years, from 1978 to 1998, I worked as a professor of surgery at the University of North Carolina in Chapel Hill. I started as a resident, then I was an assistant and associate professor, and then a full professor and associate chief of staff. And during that time, I did regular general surgery things. I published over 80 scientific papers. I had numerous grants and research grants. I wrote the American College of Surgeons Trauma Registry. And I did weight loss surgery, but I did the old kind with a big incision, stomach stapling, and the Roux-en-Y gastric bypass. As you may or may not know, in 1988, a revolution began in American surgery where we started doing laparoscopic gallbladder surgery. And in North Carolina, at my hospital, I was an early user of that technique. And over the next 10 years, from 1988 through 1997, I began using a lot more laparoscopic skills in doing my general surgery. And I was always thinking there must be a way to use laparoscopic techniques in my weight loss surgery patients. In 1997, I started visiting some of the other surgeons around the world who were doing the first laparoscopic Roux-en-Y gastric bypasses, and I started doing them also. But I have to say I didn't really like them. I didn't like cutting up near the esophagus. I didn't like dragging the small intestine up. I just did not like the Roux-en-Y. I never have. In September of 1997, I was on call for trauma when a drug dealer in Durham was shot 7 times in the belly over a disagreement on pricing with his drugs. About 9 o'clock that night, I got him into the operating room and I cut away the bottom of his stomach, some intestine, the tail of his pancreas, and the spleen because of all the bullet holes. And I hooked his stomach to the side of his intestine to hook him back together after I cut everything out. And that should remind you of the MGB. It's the end of the stomach to the side of the bowel. That's called a Billroth 2. About 3 that morning, I put him into the ICU. And I was thinking to myself, because the next day, which was a Thursday, I had a patient scheduled for a laparoscopic Roux-en-Y gastric bypass, which I wasn't crazy about. And so I said to the patient, gee, I think we should do a loop Billroth like I just did. And this was an OR nurse and a friend of mine. She said, yeah, I did them all the time. We used to do them for ulcers before they invented the anti-ulcer medicines like Tagamet. And so that was the first MGB. And after that, I did 63 more cases there, and now we're 13 years and over 5,000 people later. And as I said, in Paris in the summer of this year, 3 controlled randomized prospective trials show the MGB is better than the lapBand, better than the Roux-en-Y, and better than the sleeve. And in the sleeve's case, the MGB was found to be twice as good. So there was a gunshot wound drug dealer who led to the first MGB in 1997.
So how did he do it?
He was not really a good candidate.